Coming to the topic amenorrhea, there are mainly two types of amenorrhea, primary amenorrhea and secondary amenorrhea. So we'll start discussing with primary amenorrhea. There is no menarche by 15 years of age in the presence of secondary sexual characters, that is breast budding is present, or no menarche by 13 years in the absence of secondary sexual characters. Coming to secondary amenorrhea, it is absence of menstruation for 90 consecutive days or 3 months in a female who is previously menstruating normally, or absence of menstruation for 6 months in a female who previously had irregular cycles. The most common cause of primary amenorrhea is gonadal dysgenesis. Most common type of gonadal dysgenesis is Turner's syndrome. We also have Swyer syndrome too. The second most common cause of primary amenorrhea is Mullerian agenesis, that is MRKH syndrome. The most common cause of secondary amenorrhea is pregnancy. It is due to high progesterone. And the most common cause of pathological secondary amenorrhea is polycystic ovarian syndrome, PCOS. So menstruation. So just briefing about menstruation, the hypothalamus releases gonadotropin releasing hormone in a pulsatile manner at puberty, acts on anterior puberty, acts on anterior pituitary. From anterior pituitary, FSH and LH acts on ovary. From ovary, they produce estrogen and progesterone. Estrogen and progesterone then acts on uterine endometrium. Menstruation is shedding of endometrium. From shedding of endometrium, the outflow tract should be normal. If it is abnormal, it leads to obstruction to the outflow tract. It leads to cryptomenorrhea. So causes of primary amenorrhea are broadly divided into 1, 2, 3 and 4 and 5 types. 5 causes. It is due to defect in hypothalamus, mainly hypothalamic failure, Kallmann syndrome, anterior pituitary, craniopharyngioma, ovary, gonadal dysgenesis. The most common type of gonadal dysgenesis is Turner's, uterus, Mullerian agenesis, and outflow tract, cryptomenorrhea or imperforate hymen or vaginal agenesis and transverse vaginal septum. So algorithm from primary amenorrhea is physical examination, breast is Tanner staging, and whether uterus present per rectal examination, external genitalia, inguinal area, undescended test is urine pregnancy test, and pelvic ultrasonogram, and LSH or LH or FSH levels. So best or confirmatory investigation is karyotyping. Coming to hypothalamic failure, cause of amenorrhea, it is mainly Kallmann syndrome. Genotype is 46XX. 46XX, it is normal. Gonads are ovary. Disorder is failure of migration of GnRH neurons from olfactory epithelium to the hypothalamus. So pulsatile release of GnRH is absent. Decreased LH, FSH and GnRH, resulting in decreased estrogen. Secondary sexual characters are absent. This is called as hypogonadotropic hypogonadism. See, there is decreased GnRH and hypogonadism. Clinical features are primary amenorrhea, infertility and anosmia. Height is normal, external genitalia female, internal genitalia uterus, cervix, vagina, but infantile or hypoplastic as for their growth, estrogen is needed. And the inherited condition as X-linked recessive disorder, most common in males than females. Management is GnRH analogs given in pulsatile manner. Coming to gonadal dysgenesis, the most common type of gonadal dysgenesis is Turner syndrome. We all know it is genotype is 45XO. The gonads are ovary. Only 9 chromosomes. The ovaries undergo accelerated atresia leading to streak-like ovaries. That is, ovaries are streaked with fibers. Due to non-functional ovaries, there is no ovulation, no negative feedback on LH, that is high levels of LH, no estrogen levels leading to absent breast development, uterus and FSH. FHS is negative feedback lost and levels are also high. So there is increased LH and increased FSH. So there is hypergonadotropic hypogonadism. And mutation is SHOX gene, short stature, results in short stature. External genitalia normal female, like additional characters are webbing of neck, low posterior hairline, shield shaped chest, as pigeon shaped chest, cubitus valgus, widely spaced nipples. Congenital heart disease such as bicuspid aortic valve is more common than coarctation. Diabetes mellitus and Hashimoto's thyroiditis, and short fourth metacarpal. And also additionals are kidneys where they develop bifid kidneys. And the lifespan is slightly reduced due to cardiovascular complications. And IQ, normal IQ. The management is estrogen for 1 year of breast development. Estrogen for 1 year of breast development, estrogen plus progesterone as hormone therapy. Streak ovaries do not have chances of malignancy, so no gonadectomy. Growth hormone, height. And then we go for karyotyping should be done to rule out mosaicism, and for conception donor egg plus IVF we have to give because there is no ovulation. And coming to Swyer syndrome, just briefing about it, 46XY inactivation of SRY gene leads to dysgenetic testes, and no, they do not descend and persist as inguinal hernia. Height is normal. Mullerian inhibiting substance is absent, so there is growth of Mullerian duct, and external genitalia, testosterone and DHT are absent. Resembles exactly like a female, and increased levels of LH and FSH. There is no estrogen, breast development absent. Management, the estrogen for 1 year and estrogen plus progesterone, gonadectomy as soon as possible. Dysgenetic testes have increased chances of malignancy. And coming to cryptomenoria, is a condition where female menstruates normally but menstrual blood fails to come out due to an obstruction in the outflow tract. Causes are mainly, the most common causes, imperforate hymen, the transverse vaginal septum and vaginal agenesis. In cryptomenoria, the entire HPO axis is intact. So there is normal LH, FSH is normal. Gonads are normal estrogen levels, normal breast development, normal. Everything is normal. The only abnormality is obstruction to the outflow. So internal genital organs are also normal female organs, but obstruction is present. This is the only abnormality. Female menstruates but menstrual blood fails to come out, leading to collection of blood in uterus, leading to hematometra, collection of blood in cervix and vagina, hematocolpos, increased chance of retrograde menstruation resulting in endometriosis. Yes, this is important. And there is cyclical pain in abdomen every month but no menstruation. Sometimes female can present with urinary retention. Per abdominal examination, uterus may be palpable. Per vaginal examination, not usually done in virgin females because of enlarged uterus. And then per rectal examination is preferred, enlarged uterus. And there is lab examination, vaginal agenesis, absent vaginal opening, imperforate hymen, tensed bluish bulging hymen. See here, tensed bluish bulging hymen, cough impulse present, and opening in hymen is in. Coming to secondary amenorrhea, the most common cause is pregnancy. It is due to increased progesterone levels. Other physiological causes are lactation. During lactation, increased prolactin, negative feedback on GnRH, decreased levels of LH and FSH, secondary amenorrhea. And applied is where hyperprolactinemia can cause secondary amenorrhea. And example for this is Sheehan syndrome. Coming to normal physiology, just briefing. Normally, hypothalamus releases peptides like gonadotropin, TRH, and releasing hormones. It stimulates pituitary release of various hormones, LH, FSH, and TSH. In case of prolactin, hypothalamus releases from arcuate nucleus dopamine, inhibitory effect on release of prolactin. Dopamine agonists are used for treatment of hyperprolactinemia. Prolactin releasing factor includes TRH, vasopressin, vasoactive intestinal peptides, and acetylcholines. Dopamine receptors such as D1 and D2 are present on anterior pituitary gland, primarily have D2 receptors. Therefore, drugs with better role in testing for hyperprolactinemia. D2 is more specific than non-specific dopamine agonists. D2 receptors are specific such as carbazolene and bromocriptine. TRH releases TSH and prolactin from the pituitary. Applied is Hashimoto's thyroiditis, where there is decreased circulating thyroid levels, hypothyroidism, compensated increase in TRH, increased TSH and prolactin. This explains link between hypothyroidism and secondary hyperprolactinemia. Therefore, in all patients with increased prolactin, TSH must be measured. If TSH and prolactin levels both are increased, treat TSH first. Hyperprolactinemia causes are: it is due to normal physiological activities such as pregnancy up to 10 times, sleep, eating, coitus. Following chest wall stimulation, there is suckling, breast examination, chest wall surgery, herpes zoster infection, etc. And some cranial lesions such as cranial tumors, sarcoidosis, TB, etc. And measure the prolactin levels in morning only because it has a negative feedback on gonadotropin releasing hormone, decrease LSH and FSH. Most common symptom of prolactinemia is amenorrhea. Coming to the causes of secondary amenorrhea, there are endocrinal causes and mainly hypogonadotropic hypogonadism. So mainly hypothalamic causes are excessive exercise, stress, eating disorders, destructive processes like tumors, trauma, etc. And pituitary causes such as prolactinemia, Sheehan syndrome, destructive processes like tumors, trauma, etc. And endocrinal causes which causes hypergonadotropic hypogonadism. This occurs in ovaries, where there is primary ovarian insufficiency or there is premature menopause. Diagnosis is 2 readings of FSH greater than 40 international units. Suggestive is 2 readings of FSH greater than 25 international units. Anatomical cause is nothing but uterus. That is a Sherman syndrome, where there is estrogen, LS and FSH are all normal. The algorithms for diagnosis of secondary amenorrhea is mainly in all females complaining of secondary amenorrhea or infertility and all males complaining of infertility always measure TSH and prolactin. Secondary amenorrhea investigations of choice are urinary pregnancy test, TSH, prolactin levels, FSH and estrogen levels.